Namaskar, I'm Dr. Anshu Jindal from Jindal Hospital, Meerut. Today we are going to talk about IVF pregnancies. I know these pregnancies are very high-risk pregnancies. They are more prone to abortions, more prone to first trimester bleeding, more prone to subchorionic hemorrhage, and fresh transfer IVF pregnancies are also more prone to small for dates as they are more prone to PIH, pregnancy-induced hypertension. These high-risk pregnancies are very precious pregnancies because there is no room for any errors in your obstetrical management. And today we have none other than Professor Anjali Tempe to give us her views on how to manage these IVF pregnancies. Professor Anjali Tempe is a Director Professor and ex-head of the Department of Obs-Gynae at Maulana Azad Medical College, my alma mater. She is the IVF Incharge in the same institute. She has been the Medical Superintendent of the Maternal and Child Health Wing at Nayak Hospital from 2016 to 2019. She has received the Delhi State Award for Distinguished Medical Services in 2013. She has so many publications to her credit, 51 publications, 33 book chapters and more than 200 presentations. So let's hear what she has to say about IVF pregnancies.
Dr. Anshu Jindal has been a student of Maulana Azad, and with us she has worked. She has asked me to talk about 5 tips for successful pregnancy outcome in IVF. So I have divided it in 5 points. First of all, any successful endeavor needs a good start. Athletics or marathon needs a good start. So our start would be right protocol choosing, right embryo transfer, that is fresh transfer versus frozen. Fresh is always better for successful outcome. Third is choosing maternal age below 40. And fourth is, according to one study, if you get 14 days after ovulation beta hCG level of more than 600 milli-international unit per ml, this would definitely be resulting in a live birth. Then there is also preparation of the patient, which is all uterine factors and medical factors are to be controlled. Example being medical disorder is diabetes mellitus or hypertension control, and uterine factor or gynecological problems being the hydrosalpinx, the endometriosis or the fibroid. These are to be treated prior to IVF. So this was the first point, good start. Second point is clinical monitoring, about which I will not discuss much. Everybody knows that 2 to 4 weekly intervals patient should be seen, and you all know about it. Third is ultrasound monitoring. Ultrasound monitoring will be at 6 to 7 weeks for presence of cardiac activity, then at 11 to 14 weeks to rule out aneuploides, then at 18 to 22 weeks for structural anomaly scan, and finally at 28 to 30 weeks with Doppler, fetal Doppler, and growth chart. So this is third point was ultrasound monitoring. Fourth is prevention of complications. That being, starting from first trimester, prevent ectopics by doing hydrosalpinx clipping prior to IVF. Prevent early and mid-trimester fetal loss by detecting aneuploides and taking care of cervical factors and uterine factors, microbial infections. Then preventing multiple pregnancy. 1/3 of the IVF pregnancies are multiple pregnancies, so choosing to transfer single good blastocyst would prevent these complications, or 2 blastocysts in India, but multiple pregnancies are okay for the patients. However, they are associated with a lot of problems. So prevent as far as possible multiple pregnancy. So this 4th point is prevention of complication. 5th is adjuvant medical therapy. So in addition to normal antenatal drugs, we give folic acid to prevent aneuploides, you know that neural defects. Second is aspirin, roll of aspirin from 14 weeks onwards to prevent later on adverse pregnancy outcome in a selected patient, and finally progesterone as and when required, or in some patients till 28 to 30 weeks, so that patient does not go in preterm. So these are my 5 tips. First, again I'll repeat, good start. Second, clinical monitoring. Third, ultrasound monitoring. Fourth, prevention of complications. And fifth is adjuvant treatment. Sixth point would be a good delivery. We leave it to the patient. She chooses vaginal delivery, then 1:1 doctor-patient ratio should be there. Then only you can allow such a high-risk pregnancy or vaginal delivery. Otherwise, go for cesarean at an appropriate gestation. Thank you very much.
I'm sure you heard Professor Anjali Tempe talk about how to manage these very difficult high-risk IVF pregnancies, and a lot of your doubts would have been allayed today. I would just like to sum up by saying that these IVF pregnancies, especially the frozen embryo transfer IVF pregnancies, they have less chances of biochemical pregnancies as well as ectopic pregnancies. They have lesser incidence of preterm delivery. In fact, some of these pregnancies are large for dates. Frozen embryo transfer also gives us a chance to do a pre-implantation genetic diagnosis testing if required in some patients. So, if you like this video, please click on the like button and subscribe to our channel Global ART Forum so that we can bring you more such videos in the future. Thank you.